While we're giving folks one more minute to arrive, this slide reminded me just to send out a quick reminder, uh, how we view rounds or view grand rounds after the presentation has changed a little bit. In the first 7 days after grand rounds is presented, you can watch it on the SharePoint site, which Kim has linked to in this slide, and will also be available in the emails that come out after grand rounds. After 7 days, you can watch it on the YouTube channel that we have used historically. The Emory CME office has moved to uh, preclude us from allowing faculty or allowing attendees to obtain CME when they watch it on YouTube because of the ads that are built into YouTube, which introduces financial conflicts of interests. So if you want to obtain CME and you're not currently watching, and for all future iterations, you can watch it on the SharePoint site within 7 days of the presentation, and then watch sessions that have been around for more than 7 days on the YouTube channel. All right. With that in mind, we can go ahead and watch today's presentation in real time. We are very excited to be joined by Dr. Antzoulatos, who is an assistant professor in the Department of Neurology and a joint appointment in the Department of Internal Medicine here at Emory. She obtained her undergraduate degree here before pursuing a graduate education in neuroscience, obtaining both a master's and then a PhD. After medical school at the New York Medical College, she completed residency in a combined internal medicine and neurology program at Tulane before going on to complete a vascular neurology fellowship at the University of Cincinnati. She spends most of her time on inpatient hospital-based services in both neurology and internal medicine, and her interests include the overlap between internal medicine and stroke, especially as it relates to secondary stroke prevention. Thank you for being here today, Dr. Antzoulatos.
Thank you so much. Thank you for the invite. Thank you for letting me speak today on what I consider a very, very important topic. And so we will get into it. So today, I was asked to talk about stroke, and that was it for the prompt. And so when I think about stroke and I think about the relevance of stroke to internal medicine, I think oftentimes about either the advances and updates in ischemic stroke that are relevant and that are becoming more and more relevant to internal medicine. I think about our secondary stroke prevention guidelines and how the practice of individual stroke providers is sometimes different or slightly nuanced in comparison to what can be read in the guidelines. And I think about how internal medicine providers care for the vast majority of stroke patients. And I think often about the types of questions that families and patients have for providers and how to answer those questions given what we know about stroke and the natural history of stroke. And so it's a big field. It seems like everything about stroke is constantly expanding, but I'm hoping to use these three key areas to talk about a couple of the ways in which ischemic stroke is relevant to internal medicine. And so we'll start with advances in stroke care. And so if we think about the last 5 years of acute stroke management, that hyperacute, what happens the minute the patient comes to the emergency room, the largest advances by far are in the area of thrombectomy for large vessel occlusion strokes. So to take you through a little bit of that history, thrombectomy for stroke is new. 10 years ago, we weren't doing a lot of thrombectomy for stroke. And in fact, not until a meta-analysis was published in 2016, this is the Hermes meta-analysis that looked at 5 of the kind of recently to 2016 done trials of thrombectomy for large vessel occlusion. This meta-analysis established thrombectomy as the standard of care for large vessel occlusions. And when this was published and this entered the guidelines for the first time, we were only performing thrombectomies on large vessel occlusions, and we were performing them, at least in the guidelines, up to 6 hours from last known well. And over the subsequent couple of years leading into 2019 and 2020, there were two very large trials that established thrombectomy. It established that we could expand the population of patients with large vessel occlusion who benefited from mechanical thrombectomy. This was done in two trials. One was the Dawn trial and one was Diffuse 3. The Dawn trial, the national PI was here at Grady. Grady has been a part of every major advance in stroke care since the NINDS trial in 1995. And not surprisingly, it was a part of this story as well. These two studies showed that with advanced imaging in the form of CT or MR perfusion imaging, we could identify patients who had large vessel occlusions, who were beyond that 6-hour window and up until the 24 hours from last known well. We could identify the population of patients that had what was estimated to be salvageable brain tissue, so brain that is sick but not dead, with the understanding that thrombectomy for that patient population that was very carefully identified with imaging, thrombectomy could salvage some of that ischemic but not infarcted tissue, that penumbra, and that patients had better outcomes as a result of that thrombectomy. This changed our guidelines again and allowed us to include a much larger percentage of patients who were presenting up to 24 hours from their symptom onset and had favorable imaging that was showing a large amount of salvageable brain tissue, at least as indicated by the expectation of the perfusion imaging. And so in the last 5 years, we have spent a lot of time trying to further expand the world of thrombectomy and to try and include more and more patients into the category of patient that can undergo thrombectomy and still achieve a benefit. And the best example of this that has worked has been in something called the large core trials. And so when we think about how can we add patients to this group of people that does better after thrombectomy, one of the areas addressed this idea of salvageable tissue versus estimated core infarct. And back in 2019, our understanding of advanced imaging was that if something was estimated to be a core infarct, that was the stroke. That was not something that was likely to change significantly after thrombectomy. And what we were going after was the savable tissue. Well, that changed a lot. And the first study that demonstrated that it changed was a study out of Japan that looked at patients that had a large projected core, not salvageable tissue, but a projected core. This was a prospective, multi-center randomized trial that looked at large vessel occlusions, last known well within 24 hours. But the difference here was that these patients, based on imaging, were expected to have a large core infarct rather than a large amount of salvageable tissue. And what was found in this trial was that those patients that went for endovascular thrombectomy plus the usual medical care did better than the patients that only received medical care and did not go for a thrombectomy. The primary outcome was a modified Rankin scale score at 90 days. This is a very standard outcome that we use in stroke. And this up here are what we call the Grata bars, 4 modified Rankin scale scores for patients who underwent endovascular therapy plus medical management on the top versus the medical care group alone on the bottom. This is a modified Rankin score of 0 in white, leading all the way to 6 at dark blue. For those who are not familiar with the modified Rankin scale score, 0 is 0 deficits, feels totally normal without any observable or perceivable deficit, and 6 is dead. So this is a functional scale that is used. And what you can see is in the endovascular group, the number of patients at 90 days with a modified Rankin scale score of 0 to 3, which is considered a good outcome, was much larger than the amount of patients in the medical care group alone. Now, these patients still had considerable disability after their stroke when you compared them to the patients, for example, in dawn and diffuse. These patients were more disabled. The expectation was that these strokes were going to be larger, but what we didn't expect was that thrombectomy was going to benefit this group. And in fact, when the first trial came out, there was a lot of speculation as to whether or not this could be reproduced. But what I will say is that this was reproduced in 5 additional trials, one of which was stopped early for benefit, and one was stopped early for a different reason. I'm blanking right now, but essentially the big large core trials, which are listed here in this large analysis with these forest plots, are showing favorable modified Rankin scale scores, good modified Rankin scale scores across the board when these trials are combined, favoring endovascular thrombectomy plus medical care versus medical care alone, with a 90-day mortality that actually also sort of favors endovascular therapy as having less 90-day mortality, barely, but statistically, versus medical therapy alone. So these patients are doing better despite the fact that they have large cores and projected areas of stroke that are larger than we would think benefits from thrombectomy. How is this relevant to internal medicine, you might ask? What I will say is that with the now many trials that are demonstrating a benefit, you are going to see more patients who have undergone thrombectomy for a very large stroke, who prior to a couple of years ago would not have undergone that therapy. The comprehensive stroke centers that are appropriately aggressive, typically academic centers, the landscape is shifting in favor of thrombectomy for patients with quote unquote bad looking CT scans. These patients are taken for thrombectomy on a case-by-case basis. And so the ideal patient for this is a patient that does not have a lot of pre-stroke disability. They have a good functional baseline before their stroke. Younger patients without significant uncontrolled medical comorbidities, that don't have life-limiting illnesses, that have these good functional baselines, are being taken for thrombectomy, knowing that they have a larger projected core because they do better. You will see more of these patients in the hospital. You will see more of them in clinic. And importantly, they are going to require a different skill set of continuity of care that involves more extensive rehabilitation, that is likely going to involve a multidisciplinary team that includes PM&R, various therapies, engaging social work for different types of durable medical equipment, et cetera. And those requests and that process is going to last a lot longer for these patients. This is just an example that I created looking at all of these patients are the patients that underwent thrombectomy. These are the patients that underwent thrombectomy in dawn and diffuse in this lighter color, and the patients that underwent thrombectomy in the initial large core trial are in blue. This is a modified Rankin of 0 to 3, and this is 4 to 5, which is significant disability. And what you can see is that for dawn and diffuse, that 2019 study that was looking at salvageable tissue, a lot of those patients got better in a way that was functionally relevant. They had good outcomes. The number needed to treat for a good outcome in those studies combined is between 2 and 3. It's a phenomenal number needed to treat. In these large core trials, these patients are still doing better functionally, statistically, clinically, but a lot of these patients are going to wind up with a modified Rankin score of 5 with heavy weights in the modified Rankin score of 4 territory. These patients are more disabled and they're going to require more in the future because of those disabilities. On the flip side, when we tried to expand patient populations in a different way, we started to look at what we call medium vessel artery occlusions. And so this is just a schematic of how we characterize our major cerebral vessels using the ACA, the anterior cerebral artery, and the middle cerebral artery as an example. Large vessel occlusions are defined as these very proximal segments of the intracranial arteries. The M1, that initial MCA segment, for example, a basilar artery. Everything distal to that, which is either defined by branch points or just by segments as the artery progresses, is not a large vessel occlusion. And M2s, M3s, and M4s, as you get subsequently further out into smaller branches, are classified as medium vessel artery occlusions. A1s, A2s, A3s, P1s for the posterior circulation, etc., are classified as these medium vessel arteries. And so the question became, if we go after thrombus in these smaller vessels, is this also a patient population that will benefit from thrombectomy? And there are 3 trials that have either been published or presented. Discount was actually stopped early for harm, but Escape Mevo and Distal were both presented at the most recent stroke conferences in both Europe and in the United States. I want you to pay close attention to the thrombectomy targets for these trials were all medium vessel occlusions. And what we found was that this doesn't work, at least in the context of these clinical trials. That thrombectomy for middle vessel artery occlusions was not better, with medical management, was not better than best medical management alone. That's shown here in the major clinical trials that have been published to date, with a total sum at the bottom. This is a modified Rankin scale score of 0 to 2, where we find that there's no significant difference between the thrombectomy plus medical management group versus medical management alone. The thrombectomy group actually had a higher rate of symptomatic intracranial hemorrhage, and there were no differences in mortality. So in terms of primary outcomes for benefit, we don't see a benefit. And in terms of harm, we do see a higher percentage of symptomatic intracranial hemorrhage. And so at present, we don't really know what to do with these patients because these trials, which we anticipated were going to be positive, have not panned out in terms of results. Why? Why did these trials fail? This is a big question that we all have, and there's a number of theories for why these trials fail. One is that Mevo, by definition, is going to have a smaller territory of stroke. Is there a reduced benefit because there's less tissue to preserve? Are we more likely to have adverse effects when we start to put catheters into smaller and smaller vessels because of a procedural problem? Intravenous thrombolysis, tenecteplase and alteplase, work better in smaller vessel occlusions. So are you seeing a less effective thrombectomy because intravenous lytics are working better? And are we selecting the wrong patients? There is a very, very big debate as to whether or not there was equipoise in those trial selections. And what I mean by that is if you take the example of somebody with an M2 occlusion, which would meet eligibility criteria for these studies, and you have a patient with a stroke scale of 20 with an M2, and you have a stroke scale of 7 with a separate patient and a different M2. The patient with a 20 that has arguably very, very disabled from the stroke that they are having is more likely not to be
Don't you regularly
randomized
come in 12:30?
into a trial because of that lack of equipoise, because we are trying to make that 20 better, and because that stroke is very, very severe. And there's a very big debate about whether there was equipoise in those trials. The bottom line for internal medicine is that the landscape is changing, that you're going to see a lot of variability when it comes to thrombectomy involving medium vessel occlusions. You're also going to see the progressive expansion or attempted expansions of thrombectomy in a variety of groups to try and bring more patients into a category that will benefit from thrombectomy, but understanding that we have to be very careful as to who we select. So, and these 2 items, the large core trials and the Mevo trials, are probably the 2 biggest, we'll say, advances or changes in the landscape of stroke in the last 5 years that are making their way into the care that you will see provided to stroke patients. Moving to secondary stroke prevention. This is a huge field. This is the lecture in and of itself. What I will say about secondary stroke prevention is that the secondary stroke prevention for stroke really mirrors the secondary stroke prevention for cardiac disease, particularly coronary artery disease and MI. All of the risk factors for things that affect the blood vessels of the heart are the same as the risk factors for blood vessels that affect the brain, and we manage those risk factors essentially identically in stroke and in, for example, coronary artery disease and MI. There are very subtle differences in how we measure and how our guidelines direct us to manage blood pressure with slightly different goals in different patient populations. The lipid management is essentially the same, and all of this can be found in the most recent published guideline for secondary stroke prevention, which is due for an update, I think, in the next 1 or 2 years. The area of secondary stroke prevention that I think is the most challenging and confusing to communicate to internal medicine and the most challenging to interpret, even when reading the guidelines, has to do with how we select our antithrombotic agents and the duration over which the antithrombotic agents are used in stroke. And so I am going to start from the end here, and then we're going to work backwards from the end. But this is the general idea that I work through in my head when it comes to whether or not or when it comes to the antithrombotic management of an ischemic stroke patient. The first question that I ask is, does this patient have an indication for anticoagulation? And that indication can be related to the stroke, like the patient has atrial fibrillation and comes in with a stroke. It can also be an indication for anticoagulation that has nothing to do with the stroke. The patient happens to come in for a stroke, but we find a DVT or we find a separate indication for anticoagulation. Either way, if there is an indication for anticoagulation, the next question that I ask is whether there is an independent indication for an antiplatelet agent. So the presence of stroke is not an indication specifically for an antiplatelet agent. It is an indication for antithrombotic therapy, but not specific to an antiplatelet. What I mean by an independent indication is, does the patient have a recent MI, a stent that requires the use of antiplatelet therapy within the first year? Do they have significant peripheral artery disease that necessitates the use of an antiplatelet above anticoagulation? And if that answer is yes, then that patient is going to have both anticoagulation and an antiplatelet agent on board. And the duration of this dual therapy is going to depend on a lot of things, most importantly on discussions between usually cardiology and neurology, or vascular surgery and neurology, to optimally select the duration of therapy while trying to minimize the risk for bleeding, which we know is higher when you start piling antithrombotic agents on top of each other. If there is not an independent indication for an antiplatelet agent, those patients wind up on anticoagulation monotherapy. One of the biggest things that I see in my practice is in patients who have a history of stroke. It could be a lacunar stroke, it could be any stroke, and they are on aspirin for that stroke. And many, many years later, they are found to have a PE or a DVT, and those patients are started on the appropriate anticoagulation for that indication, but they are kept on aspirin, quote, for secondary stroke prevention. In that particular patient, there is not an indication for dual therapy. The indication for the antiplatelet agent has to be independent to the stroke itself. It is possible that it is related. So, for example, severe intracranial atherosclerosis with focal severe flow-limiting stenosis of intracranial vessels may find yourself into this category where they are on dual antithrombotic therapy, but it has to be independent to the stroke. If there is not an indication for anticoagulation, the next question I ask is there an indication for dual antiplatelet therapy? And if there is an indication of dual antiplatelet therapy, I put them in the category, are these the 21-day dual antiplatelet therapy patients, or are these the 90-day antiplatelet patients, dual dual antiplatelet therapy patients, and I will talk about these separately in the coming slides. But if the patient does not have an indication for dual antiplatelet therapy, they are on single antiplatelet therapy, and the indication for that single antiplatelet therapy is lifelong unless an appropriate etiology is discovered that may switch that antiplatelet therapy to something that is more appropriate for an emerging diagnosis, if, for example, atrial fibrillation. So these are the two principal indications for dual antiplatelet therapy that are seen in the setting of an acute ischemic stroke. The first indication is for patients with mild stroke, which in the clinical trials was defined as an NIH stroke scale of less than 4, or a high-risk TIA, which was defined as an ABCD2 score of greater than 4. The clinical trials that support this indication are the CHANCE trial and the POINT trial. And the way these trials were set up was that patients were randomized within 24 hours of their stroke symptoms. They were loaded with 325 milligrams of aspirin and either 300 or 600 milligrams of clopidogrel, depending on the trial. And then after that initial load, they were continued on aspirin 81 and clopidogrel 75 milligrams for 21 days. And after 21 days, typically patients would stop clopidogrel and continue aspirin indefinitely, although in at least one of those trials and subsequently, the selection of which agent to stop is not necessarily something that matters. It's just the idea of stopping that second agent and continuing monotherapy indefinitely or until a different etiology comes around to switch you. The indication for DAPT for longer than that, for 90 days, comes from a very old trial called Sampras. But this indication is for stroke that is attributed to focal intracranial stenosis. So as it was defined in the trial and as it has been defined in subsequent smaller trials, we're looking at intracranial atherosclerotic disease, but we are looking at a focal stenosis of a culprit vessel that is proximal to the stroke that the patient had or proximal to the estimated area of stroke in a patient who had a TIA. And in this trial, patients were randomized within 30 days of their stroke. They were put on aspirin 325 milligrams daily and clopidogrel 75 milligrams daily for 90 days. This was not a loading dose. These were patients that were maintained on a higher dose of aspirin for 90 days. And then similar to Chance and Point, after 90 days, one of the antiplatelet agents was stopped and the other antiplatelet agent was continued indefinitely. In this particular trial, the comparison was between dual antiplatelet therapy along with lipid management, smoking cessation counseling, exercise, like a very, very big medical management effort combined with stent placement in the middle cerebral artery for this particular trial. This is the data that we have. Subsequent trials using stents have also shown a benefit for medical management up until very, very recently when there has been a study showing that angioplasty may have a benefit above medical management alone. But suffice it to say, this pattern of dual antiplatelet versus stent favoring the medical therapy arm has persisted up until very recently. And for that reason, we use dual antiplatelet therapy for 90 days in the setting of patients with focal intracranial stenosis. We deviate from this all the time, and different stroke providers will have different recommendations that will seemingly deviate from what you know has been published in the clinical trials. And this is not unique to neurology. Clinical trials are not meant to be followed, specifically over time. The expansion of patient populations that would benefit is something that happens a lot, but this is how we deviate in each of these scenarios. So in these patients with mild stroke or TIA, we will absolutely point patients that are more than 24 hours from stroke onset. They could show up and they have symptoms for 2 days. And if we think that the stroke generally fits into the category that would benefit here, we will absolutely point these patients. We will point patients with a stroke scale of more than 3. We will point patients from anywhere between 21 and 30 days. because the two trials are not specific. 21 is not a magic number. 90 is definitely a bad number in this population, but we will point them for about a month, and that's fine. And we will point almost all TIAs. We do not regularly use the ABCD2 risk score in order to determine whether or not we are going to use 21 days of DAPT for our TIA. On the flip side, we will choose not to point many patients. If you have contraindications to dual antiplatelet therapy, or for example, a high bleeding risk or intolerance to a P2Y12 inhibitor, we will choose not to point you to minimize risk. If patients have medication adherence issues or affordability issues, or in general have trouble taking medications, we will choose not to use dual antiplatelet therapy in those patients to promote adherence and to make it easier for patients to adhere to the kind of general secondary stroke prevention that we know works for everybody. Similarly, on the intracranial stenosis side for using DAPT for 90 days, we will DAPT patients for 90 days for severe intracranial atherosclerosis without focal stenosis in a culprit vessel. This happens constantly, and in this population of patients, particularly the patients that are seen at Grady Hospital, there's a lot of intracranial athero. So you may see the recommendation to use dual antiplatelet therapy for 90 days when you don't have focal stenosis of a culprit vessel, but rather have just very, very bad appearing intracranial athero on its own. We will also DAPT with 81 milligrams of aspirin rather than 325 milligrams. And we will DAPT for longer than 90 days in some patients who have severe stenosis or patients who have strokes after we continually try and remove that second agent over and over and over. The best example of something like this is somebody with very critical basilar artery stenosis that hasn't accumulated a stroke burden in the posterior circulation. Those patients, we are often very nervous about taking away that second antiplatelet agent because the stakes are very, very high in a critically stenosed basilar artery. That patient may find themselves on aspirin and clopidogrel, for example, for life. They may find themselves on aspirin and a different therapy like cilostazol for a long period of time. There's a lot of variability in how we treat patients after 90 days who we think need the benefit of that second antiplatelet agent. If there's not an indication for dual therapy and the patient doesn't have a reason for anticoagulation, like the first slide that we talked about, antiplatelet monotherapy is the standard of care. Whether or not we are using aspirin versus clopidogrel versus ticagrelor, which are two P2Y12 inhibitors, as our selected monotherapy can vary widely between providers, but as long as one of them's on board, most people are pretty happy about that. At Grady in particular, and in many centers, the platelet function, the P2Y12 assays, we rely a lot on those assays to determine whether or not we are going to be using an agent like clopidogrel versus ticagrelor, which has a much lower risk of what we think of as a resistance or ineffective antiplatelet effect. Whether you believe in that or not, I think could be a whole grand rounds on its own, but suffice it to say, we rely a lot on P2Y12 testing in neurology. The dosing of aspirin will vary between providers, with some providers choosing 325 milligrams daily and others choosing 81 milligrams daily. In our secondary stroke guidelines, there is an indication for higher dose aspirin for focal intracranial stenosis. And so oftentimes when our patients do have that focal stenosis, we will keep those patients on 325 milligram of aspirin rather than dropping them down to 81 milligrams of aspirin. Higher dosing recommendations of aspirin may also be seen in patients who weigh more than 70 kilograms. There was a meta-analysis that was done with mostly observational studies that separated patients into less than 70 and more than 70 kilograms, which showed that 325 milligrams of aspirin appeared to have a benefit in both groups, but that in the greater than 70 kilogram group of people, the benefit of aspirin was not outweighed by bleeding complications. I will say there's a little bit of controversy in this meta-analysis, and I very rarely use it in isolation. But patients with uncontrolled diabetes may also have higher dosing recommendations for aspirin, and that is because of a kind of aspirin resistance phenomenon that can be seen in patients with very, very high hemoglobin A1Cs. It has to do with the ability of aspirin to interact with the platelet and pharmacology that I do not understand well. But suffice it to say, there is a well-reported phenomenon of resistance in this population of patients. And so my particular practice is if I have a patient who weighs more than 70 kilograms, who has uncontrolled diabetes, who has focal intracranial stenosis and doesn't have a contraindication or doesn't have a high bleeding risk, I am more likely to recommend 325 milligrams in monotherapy of aspirin than I am to recommend 81. I don't use any of these in isolation on a regular basis. And finally, I mentioned this before, but single antiplatelet therapy should be stopped if you end up starting anticoagulation for a different etiologic reason, except when there is an indication for an independent indication for antiplatelet therapy. Moving into anticoagulation, the most common reason to anticoagulate patients for stroke is the presence of atrial fibrillation. It is a level 1A recommendation in our guidelines. It's also in cardiology guidelines that if patients have atrial fibrillation and they have a stroke, that gives you enough points on your CHADS-2 VASC, whether or not you are using that full score or whether you're omitting sex, which has been discussed in the literature. It gives you enough points to warrant anticoagulation or to indicate anticoagulation for secondary stroke prevention. There are exceptions to our use of anticoagulation in patients with atrial fibrillation who have stroke. The biggest exception to this are patients with a very high bleeding risk. If the patient has a high bleeding risk or has a concomitant major GI bleed in the hospital, it is not something that we are easily going to be able to start for a patient with atrial fibrillation. And these patients may wind up not being on atrial fibrillation for secondary stroke prevention because of their risk for major bleeding events. The other exception that is discussed in the literature is the burden of atrial fibrillation and the burden of high rate episodes, high rate atrial episodes, and whether or not we need to start considering that burden in the context of low and moderate CHADS-2 VASC scores to limit or lower the number of patients with atrial fibrillation that should be receiving anticoagulation. What I will say about this is an older diagram. It's actually from the European guidelines. There's a newer diagram that's out that shows something that is somewhat similar. And the idea behind this is if patients have this very, very, very low burden of atrial fibrillation or have a transient atrial fibrillation in the setting of a significant systemic stressor like sepsis or septic shock, that these patients may not warrant long-term anticoagulation. The caveat to this is this concept in this literature largely applies to patients with atrial fibrillation who have not had a stroke. These are patients that are just diagnosed with atrial fibrillation for the most part. This is making its way into stroke discussion, but right now there really is a binary decision that is made for the vast majority of stroke patients in terms of indications for anticoagulation, with those patients having ischemic strokes having that indication. The alternative to anticoagulation in the long term is to consider left atrial appendage closure. In general, many cardiologists require patients to be on peri-procedural anticoagulation for a period of time before closing the left atrial appendage. But in the stroke world, when we think about strokes that are caused by atrial fibrillation and clots that are present in the atria, in that left atria, an estimated 85 to 90% of blood clots that embolize to cause strokes are thought to be found in the left atrial appendage versus the left atrium itself. And closure of the left atrial appendage has been found to be as good as anticoagulation for the prevention of ischemic stroke in the setting of atrial fibrillation. Do we see patients who have had left atrial appendage closure, who have had successful closure, that have subsequent strokes in the setting of it? We absolutely do. We see them. It's not common that we see them. Those patients typically warrant a conversation about whether to add anticoagulation on top of closure. I will say that many patients that undergo closure are patients who cannot be on anticoagulation for one reason or another. And so this is a challenge when we see this happen. One of the questions that comes across constantly with regard to hospitalized patients with atrial fibrillation is, when do we start anticoagulation after an ischemic stroke? And there are a lot of studies and a lot of trials. There's a ton of literature on when to start, and there are a ton of strategies on when to start, but they almost all employ the same format, and that is to separate strokes into small, medium, and large with regard to the geographic territory of the stroke, plus or minus hemorrhagic conversion. This is an example of an ischemic stroke with hemorrhagic conversion, which you can see on SWI imaging. And the idea being that very small strokes can start anticoagulation in the setting of atrial fibrillation or any other indication relatively quickly, within 1 to 3 days of the index stroke, and that medium strokes take a little bit longer. We typically will anticoagulate them sometime between 3 and 7 days from their stroke, and large strokes or strokes with significant hemorrhagic conversion, we will wait 7 to 14 days to start anticoagulation. And sometimes in very, very large hemispheric strokes with a lot of medical complication and a tremendous amount of hemorrhage, we go even further than 14 days. This is the rationale behind these weights is to lower the risk for hemorrhagic transformation in the setting of starting anticoagulation. And these are all of the guidelines for a variety of different countries and regions that kind of go along with this phenomenon. When you are taking care of stroke patients in the hospital, you can use this as an idea and a guidance for interpreting the recommendations that are given to you regarding the start date for anticoagulation in the setting of an indication after ischemic stroke. This is an example that I've used previously just to illustrate when and how to add antiplatelet therapy to anticoagulation as a dual therapy in patients with atrial fibrillation. As I talked about previously, if you have an independent indication for antiplatelet therapy, like a recent MI, stent placement, significant arterial disease in other areas, carotids, peripheral artery, etc., you may have an indication for a second antiplatelet agent. This is one schematic that is not by any stretch the way that this is done, but it is one schematic that is just illustrating atrial fibrillation patients undergoing percutaneous coronary intervention and a timeline that we can use as a guide for when to expect these patients to be on triple therapy, if we're even using that for a period of time, followed by dual therapy, which is typically an oral anticoagulant and an antiplatelet agent, followed by oral anticoagulation alone, all in the setting of an atrial fibrillation patient who is undergoing cardiac percutaneous intervention. This changes. There are nuance here, and I am not a cardiologist, but this is just an example of the careful consideration that is taken into account when we are planning on more than one antithrombotic agent in patients either with stroke or, in this case, in patients with atrial fibrillation. Finally, there are a number of indications that I did not talk about that have variable consensus on how to use antithrombotic agents. These include things like a subocclusive thrombus, extracranial arterial dissection, atherosclerotic disease extracranially, like very, very severe carotid stenosis, and importantly, for internal medicine and to cardiology in particular, heart failure with reduced ejection fraction when patients are in sinus rhythm with no history of atrial fibrillation and an ejection fraction of less than 30%. There is variable consensus on how to use antithrombotics in these patient populations. Neurology is often working, almost always working with cardiology in many of these instances to determine and guide the duration and definitive management of antithrombotic therapy for these patient populations. This should never be a decision that is made without the guidance of a vascular neurologist, a vascular surgeon, or a cardiologist. Moving to a patent foramen valley, I'm not going to talk very much about this, but it is something that we test for in every single stroke patient. So it becomes important to understand how we use the presence of a patent foramen valley and how we manage that. And so one of the possible etiologies for a stroke is a paradoxical embolism from a patent foramen valley. And we use a classification scale called the rope score to help us determine which patients who have a patent foramen valley, in what subset of patients is that patent foramen valley likely to contribute or be a part of the etiology that caused the stroke. And what this is a point system that awards points for a lack of risk factor and young age. And what this is telling us is if you are younger and you don't have classic cardiovascular risk factors for stroke, the more likely it is that that patent foramen valley contributed to the etiology of the stroke that you are having. This is combined with anatomical features of the patent foramen valley to create a scoring system and a scale score that further optimizes that score. So there are anatomical features that are associated with they are high risk features of a patent foramen valley that make it more likely that an embolic event will happen. That includes things like on a TE, seeing straddling thrombus in the PFO, that's a bad sign, and that probably caused their stroke, all the way to the presence of an atrial septal aneurysm or concomitant DVT or PE. All of these things are higher risk features of a patent foramen valley, and together the anatomical features, which we rely very heavily on cardiology to help us with and to help us interpret what we are seeing on a TEE, combined with a higher rope score, will drive patients toward closure of the patent foramen valley. So this is a very nice schematic that can be used. Patients that have an embolic appearing stroke who are young, under 60 years old, who have a PFO on transthoracic echocardiography, who then are confirmed with a PFO on a transesophageal echocardiography and fit this classification of having a PFO with high-risk features should absolutely be considered for PFO closure in the setting of an incident stroke. These are things that we do as this workup is progressing to try and either increase the suspicion that the PFO is the problem, for example, looking for DVTs, for looking at cardiac pathology outside of the PFO, like a cardiac thrombus that may have been an alternative etiology for their stroke. And then finally, once we get to the point where we're considering PFO closure, I think that every patient should be at least considered. We have to think about whether or not those patients need hypercoagulable testing, whether they need malignancy screening, and whether they need ambulatory cardiac monitoring to look for things like atrial fibrillation, because each of these things independently have an indication for anticoagulation, which may eliminate the need for PFO closure if a patient has a lifelong systemic reason to be anticoagulated. Finally, the last and shortest, but possibly most important part of this talk is prognosis after stroke. And so I think one of the most common things that providers get asked everywhere, at the bedside, in a hospital, in the clinic, it has to do with how well we can expect a patient to do after they have an ischemic stroke. And I think about this in three big categories. I think about the mortality after an incident stroke, I think about motor recovery, and I think about dysphagia, because those are the most common questions that get asked. So mortality after stroke is horrific. The 5-year mortality after a first ischemic stroke approaches 50% in most observational studies. These are community-based population studies. This was a very famous one out of Oxfordshire, England, that I think is still going on. This is NOMOS, which is it's a New York population-based study. Other studies in New Zealand, throughout Northern Europe, in the Middle East, have all kind of shown this same pattern, whereby the 5-year mortality rate, it approaches 50% in observational studies. That is an incredibly high mortality, and most of your patients are dying from non-stroke related deaths. These are other, usually cardiovascular deaths. Moving on to motor function, there are a variety of things that affect motor recovery after stroke. So the characteristics of the stroke, bigger strokes have less chance for complete motor recovery. Uncontrolled medical comorbidities like diabetes, hypertension, significant white matter disease are less likely to be associated with good motor recovery. There are social determinants of health, such as the availability to do rehab. There are some patients that don't qualify for rehab. They can't make it. They can't make it to outpatient therapy. They don't have the insurance that gets them to an inpatient rehab. The socioeconomic status is a huge driver for motor recovery, where patients with low socioeconomic status are less likely to make motor recovery gains after stroke versus patients that do not have socioeconomic disadvantage. Once again, the presence of rehabilitation and then post-stroke depression has a huge instance on motor recovery after stroke. The way that I look at this is the more things I add to these categories, the more I am worried about a more limited motor recovery after stroke. Almost everybody that has a stroke will exhibit some amount of motor recovery, but these are the types of things that can limit the potential for motor recovery after stroke. And this is by all means like not an extensive list of things, but these are the things that we see very frequently, at least at Grady Hospital. Oops. Sorry. Dysphagia after stroke is a big deal. 50% of stroke patients will have difficulty swallowing, and 3 to 5% of all stroke patients will need a PEG tube placed after their stroke because of difficulty swallowing. We see more of that at Grady and at comprehensive stroke centers because we happen to see more severe strokes. But the thing with dysphagia and this thing with PEG tube placement that cannot be like understated is that the vast majority of patients who are discharged with a PEG tube are not using that PEG tube at 3 to 6 months. And in fact, 80 to 90% of patients who are discharged with dysphagia that is severe enough to warrant a PEG tube are not using that. They have recovered their swallow by 6 months. There are certainly risk factors for poor recovery of swallow. That includes age, NIH stroke scale, the clinical aspiration events, especially those that require tracheal intubation. Those are all risk factors for people who may not recover their swallow, but the vast majority of patients are recovering their swallow. PEG tube is a very polarizing topic, and some patients usually have an idea of how they feel about PEG tubes before they have stroke, before they even have to come to this decision. But the idea of a PEG tube for patients with stroke is that for the majority of patients, this is not a permanent situation. So how do we talk to patients? You will need to talk to some patients about mortality after stroke. Those are patients that do not have good hospital courses, that have a lot of medical comorbidity, and whose stroke signifies the beginning of the end of their lives. Those patients are usually very obvious in the hospital, and those conversations may extend after the hospitalization. For dysphagia, the understanding that patients who need a PEG tube are not likely to be using that PEG tube, and that procedure is reversible. That PEG tube can get removed is an extremely important conversation that can be had with patients and their families. Consulting with our speech and language pathologist to get an idea of whether you think your patient will have a permanent swallowing problem is always important, because we don't want to give patients and their families hope that may not be there. And then in terms of motor recovery, my approach is to help families and patients identify milestones for motor recovery, understanding that there are some things that will limit their recovery. So I set up 6-month and 1-year expectations, and I help families to understand that motor recovery is a very long-term process. Seeing a functional improvement while the patient is in the hospital, like they start to move their arm again, is huge. That is huge in terms of the potential for motor recovery. Patients will likely make their biggest improvements in recovery. That biggest jump is going to happen in the first 6 months. And the functional recovery that you see at about the 1-year anniversary from their stroke is a very good approximation of how much their motor recovery, like the capability of that motor recovery. And that's not to say that patients don't recover after that, but 1 year is a pretty good approximation. And And finally, something that I didn't talk about because we don't assess for it in our clinical trials and we don't know a lot about it, we just know that it exists, is that there are post-stroke cognitive impairments that affect many, many patients with stroke. And this is something that will need to be addressed over time in clinics to help patients with significant cognitive problems after their stroke. So with that, I will end. I will thank my two families at Emory. I will thank my internal medicine family and my neurology family and my personal family. And I will send a very specific shout out to Emily Pinto Taylor, who came up with the title for this talk, which is more creative than anything I could come up on my own. And so I'll use the last couple minutes to answer questions.
Thank you, Dr. Antzoulatos. That was fantastic. I really appreciate your sort of very pragmatic guidance on prognostic information, in particular as a hospitalist. I have the opportunity to take care of a lot of patients in the acute setting, but not in the longer term. So we have a comment/question from Dr. Smith. I'm
Okay.
very impressed with the Marcus Stroke Center at Grady. I see that patients come from distances, including Macon and other areas for acute intervention. Please comment on the communities you serve and the growth of the program.
Oh my gosh, I wish like Mike Frankel could just like jump in here because he is the best person to talk about this. I've been here since 2021, and what I can say is that Grady in general, Emory for sure, but Grady in general is just a powerhouse for stroke. It is one of the best stroke centers in the region, in the country, in the world. We are at the forefront of almost every major clinical trial gets travels through Grady Hospital and through Emory as well for many of them. And we see patients and we accept patients for thrombectomy from all over the state of Georgia, sometimes from Florida, sometimes from Alabama. We get phone calls that start off with, there's no thrombectomy beds available in the state of Alabama. Can you help us? And that is it is an honor to be able to serve such a large community. What I will say is that Grady and Emory have a large percentage of vascular neurologists on staff that can handle these very, very complicated stroke cases. And so we tend to take a lot of complicated stroke patients from the community to try and help them with a variety of interventions. And then afterwards, depending on the patient and depending on how far they're traveling and how easy it is for them to get back, we usually are trying to follow them up at Grady, either over telemedicine or in person, to at least try to help bridge their post-stroke care into the community and back and importantly into the primary care setting, which is where the variety of these patients or the majority of these patients will receive a lot of their secondary stroke prevention. So it is a massive, Emory and Grady together are a massive center for stroke care. And I don't even know if I answered that correctly, but it is a wonderful thing to be a part of this system where we can help so many people.
Dr. Law had a follow-up question. Excellent talk. As a follow-up to that question, can you comment on access to thrombectomy in Georgia and the Southeast?
Oh my gosh. Yes. I mean, there are comprehensive stroke centers, and I think the last time I looked, there were 7 of them in the state of Georgia. There are probably more now. There are also thrombectomy capable centers, which they have not met the AHA criteria for comprehensive, but there's a lot of those as well. The availability of thrombectomy in smaller community hospitals is non-existent. It is similar to the earlier times of STEMI and the thrombectomy of STEMI, which is your percutaneous coronary intervention, not being available and needing to use lytics in smaller community hospitals. There is a parallel there. Worldwide, this is an even bigger problem. Across the continent of Africa, one of the reasons that you didn't see a lot of data from Africa that I posted when I was posting worldwide data is because that data is hard to collect. There are hardly any thrombectomy capable centers throughout the continent of Africa, let alone major cities. It is a problem where thrombectomy is not readily available, and we very, very strongly depend on the the network of thrombectomy capable centers to help route patients from these smaller community hospitals or patients or places that don't offer thrombectomy into these centers. It is a hard thing to do. We oftentimes miss opportunity because of delays. And it can be very frustrating to know that you can help a patient but not be able to reach them immediately.
Our next question, from great talk. I always learn a lot from your encyclopedic expertise. From your perspective, what are the most anticipated changes to stroke care in the coming years?
Oh my gosh. I would love to see more being done for the non-thrombectomy patient. And I know that the entirety of the vascular world that is watching right now through Emory is like giving me a sigh. But the vast majority of strokes are not large vessel occlusion. The vast majority of strokes do not benefit from thrombectomy, which has been this unbelievable force of change and good outcome in stroke. And so I would love, love, love to see like neuroprotective effects start working. I would love to see a change in the way that we think about clinical trials in terms of outcome measures for things that don't fall into this huge stroke category. I would love to see more trials looking at cognitive deficits. This is all what I would love to see. What I think is reasonable to expect is I think it's reasonable to expect clinical trials in all of those areas. One thing that I didn't mention is obviously the use of tenecteplase instead of alteplase, which we use now. That is something that has changed acute stroke care as well. So there are expansions in all directions, but the things I would very, very much like to see are clinical trials aimed at improving outcomes for patients who don't have large vessel occlusions. It's my hope.
Questions keep coming. You have certainly struck a chord with many in our audience. I was hospitalized at Grady and Stroke Center 3 weeks ago for an ischemic stroke, and I'm 26 years old.
Oh my
The
gosh.
Grady and Emory staff, nurses, and doctors were incredible. I saw an article about an increase in strokes among young adults. Are you able to expand on this?
Ooh, probably not as well as I should if I had, but um, there is an overall increase in strokes in young individuals that is not easy to explain. The By virtue of the areas that I have trained in and the areas that I practice in, the strokes that I see in young people are usually secondary to a wide variety of health issues that involve access to care, the ability to obtain like primary prevention, which I didn't even talk about in this lecture, but because of uncontrolled medical comorbidity, as we move into the future and into an era where patients may not qualify as often for health insurance, and it may be more difficult for patients with discrepancies in the social determinants of health to access care, I feel that that's going to get much, much larger for the populations that I preferentially take care of. Across the globe, I don't know that we have identified a reason why the incidence of stroke is increasing in younger patients. I'm sure somebody can probably answer that better than me, though.
Uh, for what I think is our final question, because we are actually after time. Amazing talk. Any thoughts re secondary stroke risk reduction with mono antiplatelet therapy via either PTY12 inhibitor versus aspirin?
Oh Lord, there was just a study that was posted onto our group chat about the use of clopidogrel. There is a lot of debate here. I think that I'm probably going to get some hot water for this, but I think that we can argue that ticagrelor is a more potent antiplatelet agent than aspirin. I think we can say that. Clopidogrel, I think is probably also true for clopidogrel, but we can definitely say it about ticagrelor. There are studies that have looked specifically at ticagrelor and stroke, a couple of them. I think that we don't know enough we don't know what we don't know, and we don't know enough about antiplatelet agents for secondary stroke recovery to necessarily recommend one monotherapy over another. There are a number of trials that, a number of observational studies that have suggested that clopidogrel specifically has a more beneficial effect for secondary stroke prevention than aspirin. There are also some clinical trials that don't really, or some observational studies that don't really make that claim. I know stroke neurologists whose practice is only to use P2Y12 inhibitors as monotherapy. Aspirin is easy, it's cheap, it's over the counter, and most people can get it easily. And so I think that any monotherapy is better than no monotherapy, and that there are discrepancies about which monotherapy may be optimal, that may or may not will probably never get answered, but may or may not get answered in the future.
All right. Well, thank you, Dr. Antzoulatos, for this incredible presentation. Thanks,
Thanks.
y'all, for being here, and have a great rest of your afternoon.
Thanks.
Bye, y'all.